Slides now?
It looks perfect right now, Dr. Cooper.
Okay, well, it's working again. We'll do this quickly while it's still working. I think I was trying to show you guys this slide of my parents. I was telling you it was there, but you just actually didn't see it. So this is when I was talking to you about my upbringings in Liberia and my parents. So that's coming up.
Absolutely. Perfect.
So, so basically, I was just talking about how our backgrounds and our experiences, shape who we are. And my father was a physician in Liberia. My mother worked at the library. She was a librarian at the University of Liberia. So they were involved in a lot of organizations in the community, and they always taught my brother and my sister and me, and that's who you see in the middle on the side of the photo there, about the importance of using your gifts and talents to give back to your community and to make life better for other people. So we always knew that that was part of who we were, is to serve our community. And the other photo you see in the upper right-hand corner is of the Cooper Clinic, and that's a small hospital that my parents established to deliver care to a broad cross-section of the community. So I grew up with this sense of importance of serving one's community. I also grew up in a medical family. My father's mother was a nurse. But the one thing I was really acutely aware of was that I had a pretty comfortable life, and I went to a nice private school. I lived in a very comfortable home. There were lots of children around me who didn't have those same things. I saw children who were much younger than I was, even carrying their younger siblings on their backs, carrying water on top of their heads. They didn't have shoes. I knew they lived in homes that didn't have actual electricity or running water. And I saw that they actually did fall sick. You could tell that people weren't always in the best health. And I knew that it was really hard for me to overlook those things, even though I didn't have the words for them at that young age. And I knew that on some level that seemed unfair, that some people had security and comfort and good health and access to so many good things that others didn't. So I think early on I had that sensibility and sensitivity in my life. Now, so what I was seeing was health disparities. It was really hard to articulate that, but that's what they were. And health disparities are basically preventable differences, in the burden of disease, injury, or violence, or opportunities to achieve optimal health that are experienced by people who have been socially marginalized for a variety of different reasons. And in this country, it's oftentimes based on race or income. But what we really want to see in our society is health equity. And that's when every person has the opportunity to attain their full health potential and also to achieve, their dreams. And that's one of the main ways we can do that. Is the first thing we need to do is to have our health. So I sort of was acutely aware of those things at the time. And I wrote about this in my book. And one of the things I've learned over the course of my career is that, in order to address health disparities, we have to understand how they originate. What are the sources of these things? And they actually originate from a lot of different factors, and I have them all listed on this slide, and the complex ways that these things interact with each other. So a lot of times we think about, as if we're like doctors and nurses, we start at the bottom of that blue list. We think about biological things, like we think about risk behaviors like smoking and drug use and alcohol use, and we think about genetics and things that people have inherited. And sometimes we think about how people's like social relationships or how interactions in the social environment impact their health. But a lot of times we focus on these kinds of things like behaviors and what's inherited. And oftentimes we don't look at a lot of the other things that are higher up on this list. So the reality is that all of those things, the social conditions within our country, the economic policies, the physical environment in which we live, whether it's crowded, whether we're exposed to environmental toxins, whether there's crime going on, all those things have an influence on health. Institutional practice and policies have a huge impact on health, and so do social so do health system factors. So, I think one of the things we've learned over time in the healthcare field anyway, I think public health people knew this for a long time, is that we really, if we want to help people overcome health disparities, we have to address these factors on multiple levels. But I think the other thing that we've all become more aware of in recent years is the fact that the reason we end up in the environments we're in and we experience these differences in these policies based on our race or ethnicity or our gender or other things like where we live is because of these broader societal, what we call structural factors like racism and sexism and classism. These are just beliefs, cultural beliefs and practices that are baked into our society that actually shape the decisions that we make on multiple levels and determine who gets advantages and who doesn't. And so we're really learning more about how those factors come into play. And if we want to make changes, how we have to intervene at all these different levels. So, when I came to Baltimore about almost 30 years ago now, I was acutely aware of the fact that people in Baltimore, depending on where they lived, had lots of different experiences. So I often show this map of the different neighborhoods, and the Baltimore City Health Department did an excellent job of mapping out like these different factors in different neighborhoods in Baltimore. And so these two neighborhoods, Roland Park and Madison East End, are only 5 miles apart from one another. But you can see the differences in how long one can expect to live if you're born or live in one of those neighborhoods. So if you live in Roland Park, you can expect to live to be 83 years old on average. But if you're born or live in Madison East End, which is near where Johns Hopkins Hospital is, you can only expect to live to be 64.8 years. So there's a 20-year gap in life expectancy between those neighborhoods that are 5 miles apart. And you can replicate this map in almost any major US city. Even in Washington, DC, there's a map that shows, along the subway, like the life expectancy differential between the counties surrounding Washington, DC and the city itself. And a lot of this has to do with the populations that are in those cities and the resources that have been sort of allocated to people living in those communities. And so as a result, the kinds of risks they are exposed to based on where they live. So it's not like there's nothing like intrinsic to being in Madison East End that would make people worse than people living in Roland Park. It's the way the resources are allocated and the kind of access to opportunities that people have. So I started out thinking about, early in my career, I was practicing at University of Maryland Hospital as a medical resident. And what I noticed is a lot of my patients in Baltimore City were going through similar things to what I had seen in my home country in West Africa. Frankly, I saw people struggling with financial issues, with unsafe housing, crime, lack of opportunities to obtain meaningful work. And all those things were really impacting on people's ability to follow through on medical recommendations or to be healthy. And, but I also saw that there was a disconnect between us as health professionals and a lot of the patients we were seeing. I felt like a lot of health professionals didn't really understand what people were living with. And so as a result, there were a lot of communication problems. And then people from the surrounding neighborhoods just really didn't get treated the same way that people who came from more affluent neighborhoods got treated. So I saw that, and I was determined that, not only was I going to practice medicine, seeing patients one at a time, but I really wanted to do something more on a systematic level about these problems I was seeing, because I felt like I was not addressing the bigger problem. When I would see people, I would feel like I was putting a Band-Aid on a huge wound. So I decided that I was going to go on and learn more about these systematic problems. And that took me over to Johns Hopkins, where I got some training in research and in public health. And I thought I would go out and practice public health, but what I didn't know is that, there was not a lot of science or data to inform how we would, fix these issues, because no one had really been, not a lot of people had been focusing on studying these problems. Now there had been some work. I want to give credit to all the people who came before me who had done a lot of work. It just was not like a main focus of a lot of the medical and public health research. So what I figured out was, it's one thing to look on the surface of what we see, but I really felt like in order to better understand like what was going on in healthcare and in those relationships, that I needed to look below the surface. And so I use this metaphor of the iceberg concept of culture, because it basically shows that there's so many things that are above the surface that influence, how we think and behave and how we interact with one another. But a lot of times we don't deal with the things that are below the surface. And so one of the reasons why this is a good metaphor is that, if you don't know what's below the surface, it can be pretty dangerous, right? If you think that all there is what you see on top, you can approach that iceberg and crash into it, right? And so, if we want to improve these relationships, for example, across these different groups, we really have to learn how to address the issues that are not only on the surface, above the surface, but also below the surface. So I really got interested in studying the doctor-patient relationship. And a lot of my early work, and I talk about this in the book, included interviews with patients. And we found out that a lot of African-American patients really had lower levels of trust in their doctors than whites, and that they experienced less respect and encouragement to participate in decisions about their care. And then what we said was, let's go on and really learn more about what is really happening. We know what people report, but I really wanted to get inside of that medical examination room. And so we actually got permission from doctors and patients to record their visits. And what we learned from those recordings, and we analyzed that information, is that doctors were really talking a lot, dominating the conversations when they were seeing African-American patients. And they were spending less time talking about things like home or family or other things outside of just the strictly medical issues when they were dealing with African-American patients than they were dealing with white patients. So, we found that in fact, what African-American patients were reporting was actually borne out in what we, analyzed from the data. We also saw that when African-American patients saw an African-American physician, though, that those visits were longer, that both the doctor and the patient sounded more relaxed and interested in what was going on, and that doctors actually allowed those patients to participate more in decision-making. So we knew, that doctors were probably not doing this intentionally. So we actually then went on to study bias, and we did a test called the implicit association test, which many of you may know about, which tests to what extent we have a preference for people of different social groups, whether we associate seeing the faces of people of different racial or ethnic groups or different social groups with negative concepts. And, and it's been found over decades of research that in America, over 70% of people show a bias that favors white people over Black people. And we found the same was true among doctors. So a lot of times we as doctors and nurses pride ourselves on being, we treat everyone the same, we treat everyone fairly, but we're human beings. And so I think what this study really documented was that, doctors are like other human beings, and that they do have biases where they prefer, as a group, as a majority, there's a stronger preference for whites over Blacks. And the other thing we found out, though, is not that only that bias existed, but that if people had that bias, doctors had that bias, they would actually, spend less time with African-American patients. They would actually give them less information. They would actually not engage them in decision-making as much as possible. So that was quite disturbing, as you can imagine, because when you're sick, you don't want to think that when you go in for healthcare that people are going to treat you differently, even if they're not doing it intentionally. And so this was really disturbing, and I think really led to some work. And I'm so glad that this research has brought about some real changes in healthcare, in education and in training and in healthcare practice. And there's a lot more awareness of this issue and a lot more trainings focused on doctors becoming more aware of these biases and working to overcome them. So these are the things that we identified that are important to build stronger relationships. This is in healthcare settings, but this could actually be applied to almost relationships anywhere actually that are across any kind of differences we have with people. And so communication, we know that we can actually change the way we communicate, and we had specific communication behaviors that we were able to identify as positive that we could recommend. We know that respectful treatment and is important for building trust with patients. We also know that achieving what we call concordance is important. And concordance is, it could be something that's on the surface where you and I we connect because we come from the same background, or we feel like we might identify with one another based on our gender or our age or our race. But it can also be what we try to train health professionals to recognize, is that you can achieve concordance on other things. So even if you don't look like someone, if you get to know them, you can achieve concordance on other things, like, what better understanding of what someone's values are, or what they would actually, how they would prefer to be treated, what they think is important for their care. And then you can be a better provider of that. So our work did really inform that, and our work suggested also that it was important to have diversity in health professionals because of this better quality of care that we identified when people were seeing health professionals who look like them. So why is this important? Is because we can tell from, like, this slide, this has numbers on it, but basically it's just showing that, in the US population overall, Blacks are 12% of the US population, and Hispanics are almost 18% of the US population, but they only represent 6 to 7% of physicians and nurses, So we're underrepresented among health professionals. And so this research actually suggested that not only is it important for us to be more representative, but it actually does translate into better care when we have more diverse workforce. So what else did we learn? I think I'm one slide behind here. So you're just seeing the numbers here for the US population. So I'm sorry about that. So, so the other thing we found is that we needed to test out some of interventions to really try to see if we could actually make improvements in the way doctors and patients interact with each other when doctors are caring for patients from groups that have been historically and currently marginalized. And so we did test a number of solutions. One of them focused on hypertension in the Triple P study, and then one of them focused on depression in a study called the Bridge study. And both of these studies included communication skills training programs for doctors, and on some level, some program to help patients. So the Triple P study, we used community health workers who actually helped African-American patients become more prepared for their visits with doctors, and to ask questions and to state their opinions and to feel confident in doing that. And then in the Bridge study, we had social workers who actually coached the African-American patients with depression and helped them to identify specific issues that they wanted to have addressed within their care, and to articulate that more affirmatively in their care. And we found in both studies that we were able to truly improve the health of patients. So blood pressure control was improved in the Triple P study, and depression was improved in the Bridge study. So we know that there are ways that if our healthcare system develops the appropriate strategies, that we can actually overcome disparities in care and outcomes for common conditions. So that's a healthcare focus. And we also know that for patients, what did we learn from that? This is one of the tools we learned from patients for our work with patients, is that, patients and family members, you are your strongest advocate. And so because those community health workers were able to really help empowered patients to do their part, that's why they got better. So we came up with this tool called Do Your Part, which actually we feel like it could be very helpful to patients, actually to everyone, but particularly if you are from a group that has been marginalized in society, it's particularly important for you to feel empowered to do your part. So preparing for your doctor's appointments, acting during your visit, reviewing the key recommendations, and then taking your recommendations home so that you can remember what you need to do to take action. So there's a lot of this described in the book in more detail. And so I wanted to share that tool with you. Another lesson learned was for doctors. This is a tool that we actually use with training of health professionals, is the Relate tool. And so it's not just, this is just a reminder. We know it takes a lot more work than just giving people a list like this. They really have to practice these skills. They really have to get feedback from their colleagues and from their patients about these issues. But just to help people remember when they're seeing patients, and especially when they're seeing someone who looks different from them and who has life experiences that are different from theirs, to respect the humanity of that person in front of you, regardless of whether you like them or whether you agree with what they're saying. To imagine yourself in that person's shoes, empathize with them, to listen more and talk less, because we found out again that doctors were talking a lot and lecturing to African American patients. To ask themselves more, what assumptions am I making, whether they are really based on facts about this person? To talk with patients about themselves and not just about their medical problems, and then to engage them in problem solving and making decisions about their care. So that's just another one of the strategies that we have begun to use in training of health professionals. So then I went on to talk about the Center for Health Equity, which I'm happy to talk with you all more about, but I'm just honored that this center has been in existence since 2010. And our mission is to promote equity in health for socially at-risk populations through advancing scientific knowledge. So that's through research, through educating and training leaders. So we train students in the health professions, but we also work with community leaders as well to provide them with leadership skills and knowledge related to health equity and how they can become strong advocates within their own communities. And then through partnering, we partner with several community-based organizations and groups to help us raise public awareness of inequities and to help us promote the findings that we have from our work. Actually, they inform all of the work we do, all the way from the development of the research questions to how we conduct it, to how we interpret the findings we have, to how we engage with people to be involved in the studies. So we really engage strongly with communities, and I'll tell you more about how we do that. So the center now has over 45 faculty, and we've trained over 150 scholars in the Baltimore, Washington area, but then we've also developed online programs where we've trained about 8,000 people worldwide through our online programs. So, and in 2020, we celebrated our 10 years of promoting equity. So again, here's our three-pronged approach: engagement, research, and training. And through our community advisory board, through our health system partners, and then we also have local, national, and global policymakers. So we're involved with, I saw Dr. Carlicia Hussein was on the webinar earlier. She was one of our early partners from the Maryland Health Department of Health. We have people from Baltimore, from Maryland. We interact with National Congress members on bringing about policy changes. And we also work with global organizations like the World Health Organization. And then we conduct our research studies, and those are just a couple of examples of some of the research studies we do. And then, like I said, we do our courses. We have a monthly speaker series called a Jam Session, which includes the music that is favored by the speaker of the month. And so we celebrate culture and heritage during those sessions as well. And then we have individualized mentoring opportunities for students, all the way from undergraduates to graduate students and to faculty. And we've also been involved, like I said, our community advisory board is very active. We have about 60 members now of that board that come from various organizations, healthcare systems, educational institutions, government, from private and faith-based organizations, as well as businesses. So it's really important for us to all work together. Like, one of the points I make is that because health equity is such a complex problem, and there are so many different things that need to be done in different places, it's not all going to be like one group of people that will get it solved. And so that's why we all come together. We have quarterly meetings where we talk about what each of us is working on and how we can support one another. And we also have separate meetings on specific topics. We have workshops, we have retreats, all of those things. And it's a forum where we can support one another, because this work is hard, and we need to keep each other uplifted, So it's been a really enjoyable experience. One of the things we did about 5 years ago is to take the center to a global level. So I just wanted to show you that, we thought it was important, not only because health equity is a global problem, but also because, my interest in this work originated back in Africa. So I wanted to make sure some of the work I was doing here would also help people back in Africa, and that we could learn from what they were doing there. So this just shows a little example of some of the things we've done. One of the things I did was to become involved with the Ebola vaccine trials, to make sure that they were being done in a way that was culturally sensitive and appropriate for people in West Africa, and that it wasn't just a matter of, people from other places coming in and like experimenting on people from those countries. So to really build trust with communities and to make sure that the work was done in such a way that it would help people in those countries. And we've also been working in Liberia and in Ghana on issues related to hypertension. And because of this work, I think it was very helpful to me when COVID came on board, because I was able to then be helpful to folks who were working on COVID vaccine trials and making sure we could engage diverse communities in that work. So this just shows you some of the things that we've learned since COVID-19. It really kind of shone a magnifying glass on what we had known for a long time about disparities in health. And one of the things that we came to learn, though, is that we needed to address lots of different things. Like I had mentioned before, we needed to address things like building trust with communities. We needed to make sure people had their basic needs met, like for food and housing. We needed to make sure they had paid sick leave. All of these things. I wrote about a lot of these things during the early months of the COVID pandemic, and I went on national media to talk about these things. So there's a whole chapter that talks about what we've learned from the COVID pandemic, and the fact that it's not only going to be a matter of us making sure that people have access to medications and vaccines, that is critically important, but it's also going to be about us addressing those structural factors that created the disparities in the first place. So we can't forget about that. Once COVID is over, we're still going to have those same problems we had before with, people of color dying, at much younger ages, and being much sicker for most of their lives, even children, than other groups. So that work continues. So there are some take-home points that I want to leave you all with, and then we can have our discussion. So I'll try to go through those pretty quickly. So the take-home points are that health inequities harm all of us because we're all interconnected. We've really seen that through this pandemic. I think everyone here would probably agree with that. And so this just reminds me of this quote from Dr. Martin Luther King, who actually said this literally, like he wrote this letter from the Birmingham jail, literally when I was born. So I feel like I came into this world knowing that I was going to be working on these issues. He said, "Injustice anywhere is a threat to justice everywhere." So that's the first lesson. We're all interconnected, and anytime one of us is affected, we all are. The other take-home point is that if we have health equity, it actually improves conditions for everyone. It's not only saying, oh, we've got to go help these people over there. It actually is better for everyone. So if you think about something like the fact that, if people are sicker in certain parts of our society, that it actually costs us all more money. We are less productive as a society. We are less competitive globally. We have conflict amongst ourselves. I think we've seen that, more than ever. We don't have as much social solidarity. So when we have health equity, it actually makes things better for everyone. And I give the example of, for example, when you have, let's say, those curb cuts, when you're trying to cross the street and you notice that there's a ramp that goes down, they make those for people who have physical disabilities, right? But how many times have you noticed how helpful that is? Like, suppose you're riding a bike or you have a child who is in a stroller. Isn't that curb cut helpful to them too? So it was really created for a specific group, but it actually is a beneficial thing for everyone. And that's how health equity is. The other third lesson is that equality is not equity. Some people think that if we just give the same thing to everyone, then we'll be fine and we can all go home. But as you can see from this diagram, this is from the Robert Wood Johnson Foundation. If we give everyone the exact same thing, that's at the top, equality, that doesn't mean everybody's going to be able to ride that bike, right? We have to give according to what people need. And that's what equity is making sure that people's needs are met. We meet people where they are, not that we just give everyone the same thing. So then the fourth take-home point is that we actually have research that has already identified programs and policies that will advance health equity. All we need to do is actually use it and do it. So we talk about 3 different approaches: creating communities of opportunity. And that just mainly means creating communities where people have resources, basically things like early childhood care and development, where there's work opportunities for everyone, where there's good quality schools, where people get paid a living wage, where there's healthy housing. We know all those things will improve health equity, but we just haven't really had the political will to do it. So that's what we're working towards. We need to build more health into the delivery of healthcare. So we shouldn't be only trying to fix problems once people are sick. We should prevent them from getting sick in the first place. So let's talk about how we can do things to keep people healthy rather than waiting until they get sick. Let's give everybody health insurance coverage. Let's make sure everyone has access to primary care. So, and then finally, the last one, which is probably the hardest one though, is that we need to build awareness and empathy and support and political will. And how do we do that? I think some of it is really through making people aware of how interconnected they are with other people, and how the reason that people experience health disparities is not only because they made a poor decision, it's really because we as a whole society have made it impossible for them to make good decisions. So we should all be responsible for this. And the more I think everyone's aware of that, and the fact that, health disparities affect a lot of different groups of people, and it's everyone's problem, then I think they will be able to support the policies that will address equity. So then finally, it's like addressing health disparities means that we have to leave our comfort zone. So a lot of times we think that, well, we just need to take care of our own. But I think the old adage about, we are our brother's keeper is like, we may have to leave our comfort zone, go out and meet other people who are not like us, try to see ourselves in their shoes, make sure we're communicating clearly with people, that we're listening to what their concerns are, that we're trying to build some understanding and concordance with them, and that we are asking ourselves and checking our own biases and assumptions. And so this is the same thing, basically. We each have a role to play. Nobody can do this by themselves. We have to work together across our disciplines, across our sectors, across our neighborhoods and communities. And in that way, we can learn from one another and then jointly implement these solutions. And I know it sounds like pie in the sky, but most of the major changes that have occurred in our society and our world have happened as a result of people of goodwill coming together and basically making, working towards that change and speaking up, so most people want this for themselves and for others, but we can't be the silent majority. We have to speak up and do our part. And so, I just want to say that I'm going backwards for some reason here. So let me see. Yeah, this is what I want to say is that that this is an old African proverb, that says if you want to go fast, go alone, but if you want to go far, go together. So I'm going to stop there and I will take your questions.
That was a wonderful summary of not only your book, but the research that you've been doing over the years. Yes, we have a number of questions that people have given us, but I want to start off by just asking one question of you. Throughout reading the book, you acknowledge that indeed, yes, there is structural racism, and that you acknowledge that it does manifest itself in medicine and healthcare. And I can't help but think back, we're talking about, 100 years ago when we had the Flexner report, and when that deconstructed medical opportunities, where we were left with but 2 of the minority serving medical schools. And I can only think of the impact that that has had on not having, a diversity of the physician workforce. So my first question to you is, can you talk about some solutions to increase the diversity of the physician workforce?
Yes, well, of course, it starts very early, right? It starts with that early childhood, that investment in early childhood development, because, in order for people to be able to compete in the science, technology, engineering, and mathematics fields, they have to have a very strong foundation. So I think our society investing in that is critically important. I also think that mentorship programs have played a critical role. So I think, for example, programs that actually strengthen and fortify like the faculty within these medical schools is so important, because we serve as role models and we attract others into the field. So I think those kinds of programs are important, and what we call pipeline programs. So really starting all the way from, junior high school and high school, is getting people exposed to, to health professionals and to scientists, and to get them working. We have lots of summer programs where we have students come in who are from groups that are underrepresented in medicine and science. So I think it starts way back, but I think all the way with early childhood and pipeline programs, but then we also have to have the support programs within the institutions. I think we have to change the leadership culture within the institutions. So that's a lot of where I've been focusing my work, is in healthcare, not only in the actual delivery of healthcare, but also the culture of the institutions. Who is in leadership roles? How do we actually express our mission? Those are the kinds of things that attract people into working in those fields. If they don't see anyone that looks like them and the culture is not welcoming to them, they're not going to want to pursue that. So I think we have so much work to do on so many levels, but the point is that each of us can play a part, and it doesn't always have to be somebody who looks like us. I mean, I've had mentors of all different backgrounds. So I think if we can get other people who are allies from other groups who really are similarly committed, I think that that will also help our efforts.
I see a couple of questions that are also focused in the area. Juliet asked, should the US government help fund education for minorities who would like to pursue a medical career?
They certainly should. And I mean, there are many programs that do that, but probably not enough. So the government actually supports a lot of medical education and a lot of graduate medical education. And I think there's been a lot of funding that has gone into enhancing diversity in the health professions. Some of it even within some of the more recent, legislation that's come about. So there are efforts there. It's just that we're so far behind. We have hundreds of years to make up for. So it's going to be a long time before we actually see all of the fruits of our labor. But I think there are a number of people, especially a lot of our folks who are in Congress, who are really advocating and pushing for all of these supports.
Oh, I'm glad that you mentioned that. I did have a question, and it certainly goes to your recent role in which President Biden has appointed you to the President's Council of Advisors on Science and Technology. Do you see that they are going to play a role in decreasing health disparities?
Yes, we are. I mean, I think
Okay.
clearly President Biden said that one of his main concerns was that the benefits of science and technology should
Mhm.
accrue to everyone and that it should be used to advance health equity. So that's one of his priorities that's in
Okay.
there. And so we're looking at achieving health equity through like improving the functioning and the effectiveness of the public health system. But we're also looking at equity in areas such as how does climate change negatively affect communities of color, and how do disparities in access to STEM education influence lack of opportunities for jobs within the new sort of technology sectors. So we are examining equity in every single domain of our work.
Um, Denise mentioned that, the five miles apart story was indeed heart-wrenching. Can you speak a little to, are there some low-hanging fruit that can immediately address some of those great disparities that we actually saw?
Yes, I mean, I'm this very strong proponent of community health worker programs. I don't know how many of you are familiar with community health workers, but these are people who are from our communities that are disparately affected by all these negative health factors. They know the people, they know the challenges they're facing, and they are so committed and hardworking. And all of the programs that we have tested using community health workers have shown dramatic results. And so I think funding for community health workers is an area that shows incredible promise for helping people in communities that are, under resourced to better cope with the issues they're facing, to access resources that are available to them. Because in many cases, the resources are there, but people just don't know about them and don't know how to access them. And that's where community health workers come in. They also provide support, social support. They help people navigate the complex social systems as well as the healthcare systems that we need a PhD basically to figure out what kind of health insurance to sign up for. And so community health workers, I think, are a very promising strategy. I call them a low-hanging fruit because I mean, we still need work to make them effective, and we need to support those people as well because they have their own challenges. They're from the same communities that are experiencing all these disparities. So we need to pay them well. We need to take care of them, but we need to respect them and the value they bring because they definitely improve the lives of other people.
Juliet wants to know, what is your view about universal health care and whether or not that may be a solution to health equity?
So, I am a strong proponent of universal health care, and I think it's something that that without it is going to be difficult to achieve health equity. But I don't think it's the only thing we need. So, we know that there are people who have universal access in Canada and in the United Kingdom, for example, and we still have disparities in health. So I don't think that it's going to fix everything, but I think it's certainly like the first step. And so I think the Affordable Care Act, we know we have strong evidence that the Affordable Care Act has actually really reduced disparities in numerous areas, all the way from sort of childhood asthma to maternal health, and to things like, heart disease and diabetes. So we know insurance is critical, but it's not the only thing.
In your research, and this is from Sharon V, it says that ageism is also a factor in healthcare disparities. And as a caregiver to parents, what are, can you perhaps talk to that, and especially when you're dealing with parents that have cognitive or mental challenges, how do you best address and avoid further disparities in the care that they receive?
Yeah, it is so heartbreaking because, the thing is, as we all know, none of us is like unidimensional. Many of us belong to many categories of, that experience disparities. So imagine if you are an older person, you're already at risk. We saw that, people who were in nursing homes, for example, were much more likely to become sick and to not be able to get the care they needed, especially during COVID. So imagine if you're an older person and you're also a person from another group that's socially marginalized, like being an African American or a Hispanic or an American Indian or even an immigrant group. So we know disparities are magnified for people who belong to multiple risk groups. I think keeping in mind, who are people that are the most likely to be left out in all of our considerations is going to help us to better address those issues. So I think if you're interested in addressing health equity, think about who's been left out and who's not really, thinking about this particular group of people, and help them become an advocate for them. We use things like peer support to do that. We use things like I said, community health workers. There have been numerous approaches that are successful in older people. I'll tell you about one called the Capable program, for example.
Okay.
For the longest time, everybody thought that older people needed, they all needed to be either in a nursing home or they needed a home caregiver or something like that. Some people actually do need that. But what this program found is that people were most helped who had somebody, they had like a nurse, calling to check on them, that sort of thing, periodically. But they also found that having a nurse and a handyman, somebody that would just go to people's houses and fix things that were broken in their homes, that's what led to better health outcomes and functioning in older people. So we have to figure out what people need and then address that specific need. So as you're talking about, your friend's talking about her older parents, maybe what we would think they need is not what they really need. We have to figure out from them and from living close to them, or who takes care of them most closely, listen to what those specific needs are and tailor the programs and the resources to them uniquely.
Can you speak of, you spoke of diet, and I was reading in one of the hypertension studies that you were talking about, and this kind of touches on one of the questions here. The typical American diet is, the cause of so many ailments. And, whereas here in the US, we eat from a can, whereas in other countries, we may eat from the land. What have you found that has worked to get people to eat healthier?
Yeah. I mean, it can be really challenging. We know that there are lots of things that keep people from eating healthy. Some of it just being that they can't even find the fresh fruit or the fresh produce they need to eat healthy because they don't have any fruit markets or, fresh food markets close by. But so what we found is first of all, people knowing more, having that information about what's healthy, but then also having more information about where to get it and for how to get it. And so one of our programs, we actually had somebody who was a health coach who talked with people who had high blood pressure about what were healthier options for them, things with lower salt, things with higher levels of vitamin C and nuts and beans and things like that. And then help them figure out where they could buy those things for an affordable, at an affordable cost. And I think that's what people need, is to know where can they get, if they can't get the absolute best thing, what is another suitable replacement that is affordable that they can get. And we were able to show that, when we could tell people what to do and how to read the food labels, they could actually find an option that was affordable and healthy to them, And I think so it's a matter of working with some of for example, the SNAP program to figure out how we make the choices in there like more healthy, how we provide more home delivery for people who can't get to the places that have all the produce. So I think that those, a lot of those options are there. And then of course we have programs where people are actually at just being active within their own communities and doing their own farming and things like that, co-ops and things like that. We know that those kinds of things are really active right now. But I think a lot of the advocacy in around food and diet actually has to be within the food industry, and they have to be held accountable for like not creating all these unhealthy products and marketing them to us as well. So I frankly think that it's on multiple levels, and a lot of where we're successful is getting people to put what the content is in the of the food, like on the labels and in the restaurants. Because I think when people look at some of those things, they're like, oh, I'm not going to eat that now that I know that, you know. So all of those things, I think.
Okay. You wrote an interesting essay that was actually part of the National Urban League's State of Black America in 2020. And it was titled "The Silver Lining in COVID-19's Dark Clouds." And you sounded hopeful. Why?
Yeah. Well, you know, like I said, I think to do this work, you have to be a hopeful person. But I think what gives me hope is the people I see every day. Honestly, I meet the patients I meet who are actually, there are people who I meet who come from very difficult circumstances, and you can still see that they are doing the very best they can, you know, to take care of themselves and their families, you know. So I know that people have that within them. I know I can see them supporting one another and trying to make those good decisions, doing everything they can. I see my community partners who are working day by day, trying to hire and train the best people to go out and serve their communities. I see people going out and like writing letters, you know, to their city council people and to, you know, their Congress members. I see people from different organizations making sure people get out and vote. So, and I, especially in the churches, I see all the work that the churches did to get people vaccinated during this time and to make sure they had the food and, you know, the things they needed and housing. So there's so many people of goodwill, and I think that's what gives me hope, is that there are so many of us that are working in the right directions, and if we can pull the right levers,
Yeah.
you know, that have the most influence, I think we are going to see progress. And I know part of the issue is that we all are like impatient and we want all things to be much better like right away. But I think we have to remember where we've come from, and the fact that every change we make and every effort we make is incremental towards something better, you know.
Okay. I'm going to move on to a couple other questions. I listened to you, and I believe it was might have been Dr. David Williams, you know, talking one time, and you know, there is a myth about a post-racial society, and I think there are still a lot of beliefs that perhaps we don't have the racial inequalities that we do. And I know Dr. Williams, I think he mentioned something like it was back in, it might have been 1978 when the racial gap was closed, where I think Black households were making 59 cents for every dollar that whites make. And that back now it's 218, 219, and the gap is still 59 cents. What does that say? And how does that, how can that be used to convince people that no, things have not gotten significantly better, where we can say, you know, racial inequalities are things of the past?
Yeah. Well, you know, I think that if people who don't believe that racial inequality is a problem now, I don't know how to say this, but I think they don't want to know. They don't want to see that, you know. I think that there are enough people that know that it's real and that know that it's a problem, that I think we should expend a lot of our efforts on bringing those people together to bring about changes. I think people who are in denial over the fact that there are racial inequities, I don't think that giving them any more data or information is going to change their mind. I think what we have to do is to appeal to people on a different level, is to help them to see themselves in the situation. Because I think a lot of times people get this us versus them sort of mentality. And so I think what people who aren't minority or who don't believe this need to see is to see it maybe in someone else that they feel more connected to, or to see the problem in a way that speaks more to them personally. And then therefore then to become convinced and to work on it, maybe not by using race as the example, but everybody knows what it's like to be left out and to not have opportunities, or in some shape or form. And I think that's what we have to do. And I don't think any amount of sort of trying to force people to come to a reckoning on this is actually going to change their minds, unfortunately. I think it's more appealing to them, like where they are, but I also think it's telling stories rather than sort of providing statistics and or like sort of accusing people or putting them on the defensive. I think it's more having people get connected with other human beings and identifying with what it must be like to be in their shoes, and therefore becoming convinced that they want to see change.
Thank you. There appears to still be a lot of bias when you look at, the rates in which African Americans have, let's talk about breast screenings or colorectal screenings or things of that type. And it will even put in mental health screening and looking at mental health problems, where you find that African Americans, are not being screened, are not getting that type of care. You've talked about, how to change physician attitudes and how to, bring more of a level of connectiveness to improve the communication between physicians and patients. But I recall you also talked about how equity needs to be the new metric for professionalism, the new metric that talks, just as we look at quality, we look at other metrics, how do we elevate equity to being a metric where the performance of physicians and other health providers is being judged on how they are improving equity?
Right. Well, I think health systems have a big role to play in that. And I also think people who are payers for health care play a big role in that. So they determine like how much people get reimbursed based on performance, because we've shifted. We used to just pay for kind of service, like pay fee for service system where you were paid by how many people you saw. Well, that sort of changed now, where reimbursements are really going to be reflecting quality, right? But the problem is you can't get quality if like a whole subgroup of the people you're serving are not doing well. So the only way you're going to get everybody up is to really look at folks who really aren't doing that well and try to figure out what you're doing wrong there. And so we've been making that case with health system leaders, with people who sort of set the performance standards and determine where the incentives, how the incentives are allocated. And I think when you do that, then you have people who are they're being held accountable to that metric, right? And so, for example, IBM Watson, we worked with them to include equity metrics within their performance. Like, so if people wanted to get, this like certificate that says by IBM Watson that you are like a high performance community hospital, you have to have done certain things to promote equity within your community. So we're really working on that. And similarly with physicians, we are working with, we're not just going to train you to behave in an unbiased way, but you're going to have to take board exams and you're going to have to perform at a certain level to get recertified, and that people respond to those things. So it's not just a matter of, you have to hold people accountable. And in some ways, you wish people would just be motivated to do the right thing, but that's not always the case.
Okay. Have another question for you. This one has to do, again, with mental health. And it says mental health seems to be one of the most gray areas of healthcare. And are there any ideas that you have on how we should best approach diagnosis, plan of care, budgeting for long-term housing, continuous medication, any plans that may, certainly, erode at some of the, inequities and disparities that currently exist?
Yeah, I mean, this is a topic that is like, it's deeply troubling because not only are there disparities within mental health, but when you think about people who have mental health challenges and those who don't, there's such a gap between like what those people, experience. So people who have mental illness, regardless of race or whatever, are much more likely to be, poor, to not receive like the services they have. They die at younger ages, all of those things. So we've got a problem that is like, across the board. But like I mentioned before, if you belong to more than one vulnerable group, then you're, in sort of a double or triple jeopardy, right? There's no simple answer to this, but I do think one thing that has really received much more attention and support is parity in mental health coverage, so that people at least can get the same sort of coverage for mental health treatment that they do for physical health treatment. Because for the longest time, it was a case where you could get treated for your hypertension and diabetes, but if you had mental health issues too, you were kind of on your own. There's a lot more sort of advocacy around creating parity. But I think the mental health field, honestly, is really suffering from like the workforce is inadequate for the amount of mental health issues that we have. We don't have enough clinicians who are trained in that field. So I think we're going to similarly, like what I mentioned to you about community health workers, we're going to have to train people, not only physicians, but other people within healthcare, and then lay people to be better equipped to support, people who have mental health challenges. So peer support programs are going to be really, really important to put in place. Even community health workers, now we have a special sort of mental health training that they go through so that they can identify when, somebody's in a crisis, and at least be able to refer people to the right support. But I mean, mental health is a heart-wrenching crisis in this country, and it's gotten worse since COVID. So I think we all, as individual citizens, have a real responsibility to learn more about it and to learn what we can do to identify and support those around us who are struggling.
You often talk about not just the role of health institutions, but the role of individuals, what each of us can do. Can you maybe unpack that a little bit so that we can walk away with maybe a couple points on what can I do? I mean, I don't run a hospital, but I am in touch with people all the time. I work in my community. What can I do?
Yeah, I mean, I think we all have to ask ourselves, even if you're not the director of a healthcare institution, where are you on a daily basis where you interact with other people, and that where you have a voice or an influence, wherever that is, whether it's just on your street and in your neighborhood? Can you get more involved there? Can you speak up there for things that you see that aren't well, are not going well, or where you feel like people are not being treated well or being left behind? Can you, just be more informed and activated about things going on in your broader community? That if you notice things, people are living in homes in poor repair, or that there's not enough funding for the schools or something like that. In your church, I think our churches, I think our other civic organizations, even a lot of our sororities and fraternities, with their strength in numbers, when we come together and we identify something is an issue and we want to address it, support it, write letters to people who are in, decision-making roles, we have power. We just need to use it. And it does seem overwhelming if you just sit within your house by yourself and think, what can I do? but there are the people you come in contact with daily. There are organizations you belong to or institutions you belong to where you have a voice and where you can bring other people together to support a cause. So that's what I encourage us all to do. And I think we can go out and vote as well. I mean, that's something that a lot of people don't think about, or they think, oh, well, what's the point? Well, that's a significant power that we have. I know it's being threatened in many ways, but we are also working around a lot of those things. And we need to make sure that we wield that power, because if we have a voice in who becomes our leaders, because and those people determine our future. It's people think a lot about voting for the president and the vice president and so on and so forth, but really voting for the council member within your city or the mayor, getting involved on that level is just as important, if not more so.
Thank you. Want to turn now and let's talk about trust. And let's talk about Johns Hopkins. I'm glad to see that this question has popped up. It talks about Johns Hopkins history with Henrietta Lacks. Trust issues obviously popped up again with the COVID vaccine, especially with the use of social media. How do we change the narrative without turning a blind eye on the past?
Yeah. Well, I think we all have to acknowledge that there were some pretty horrible things that happened, in the past. And maybe that even continue to happen to this day, but not to the same degree or at the same level as some of those things that happened in the past. Some of those things that happened in the past can't happen now because of, some people like us speaking up and advocating for change.
Yes.
So there are laws and regulations in place that prevent people from doing things that will intentionally harm others like that now,
Mm-hmm.
So I think we need to remember that things have changed. We need to remember that there are more people who have our interests at heart, that are involved in the leadership roles and within the structure. We need to support those individuals, and realize that, our part in this is to actually, it's understandable for us to not trust, but I think we have to ask questions. We have to seek people that within these institutions and these structures that we do feel that we can trust, to get that information and then make an informed decision, And then once we've done that, is to go out and be a voice to other people who are similarly skeptical. But I think we've got to remember that things are not what they were before. And that, yes, there are bad things that happen and that have happened, but there are also advocates and supporters, and there are changes that have been made. And we need to recognize those things and benefit from them, because our failure to embrace those things mean that we will continue to be left behind and to be harmed.
Can we just talk a little more about trust and what are you advocating right now, and what has come out in the research that you have done regarding, communication with physicians and with patients, where clearly communication issues have really arisen and have certainly been, at the root of, disparate care. But what is being done now, or what do you think should be done? You got to start with the new doctors. I mean, those that are in medical school right now. Yes, those that are providing care right now. But what is it that we can do to begin to develop situations where patients trust physicians once again?
Yeah. Well, here's the thing. I think a lot of people trust their own physician. We've actually really seen that. A lot of people will say they trust their own physician. They just don't trust the whole system. They will just broadly say, well, I don't trust most doctors, but I do trust my doctor. So I think some of it is identifying a person who, if you know what you should be getting, that's part of it, is understanding more of what you should get and what you should receive, as a patient. And if you are seeing that you aren't getting that, using your power to make that decision to say, you know what, I'm not being treated the way I should be treated. I don't, so I don't have to put up with this care. I can go somewhere else. Now, I know it's harder for some of us to do that than others, but I think we have to rely on our other support systems, our connections to like get us to a better place. So I think just basically feeling more empowered by knowing what it is we should be receiving. I think some of it is speaking up honestly to the person that you're seeing right in front of you, because I think a lot of our health professionals, most of the people I see and work with every day, they want people to feel better. They want people to get well. They don't want to, people don't go to work every day and work at a hard job like that, to see other people like suffer and not do well. If they're not doing what they should be doing, it is a lot of times the whole system around them is not supporting them to do that, or they're not really, there's something that they're missing. So I think really making that effort to connect with that person on a human level to say, you know what, I feel like you're not like understanding me, or this is what I'm really worried about. I'm wondering about whether you actually are more worried about trying to get through your day right now than helping me with what my specific problem is, And I think approaching people on an individual level like that is more likely to result in something positive. And just saying, listen, I want to be healthy. How can I do that? I need you to help me with that. And if you can't help me, where else can I go for it? Or and is there something that I'm missing here? But I think that's important. I think, I think we can do that. And I think if we aren't getting what we need, I think we can express that, to people who can help us. I know I'm making it sound easier than it is. Believe me, I'm, being a physician myself, I hear stories from my family members every day about how difficult it is. I just think we just cannot give up. We have to find, advocates or people who are willing to help us sort of navigate that system. Inevitably, there's somebody you're going to find who is going to listen to you and who is going to make that extra effort, because really, when people aren't doing that, everybody's dealing with their stuff, And unfortunately, health professionals, they should be able to rise above all of that, but there are people too. And, this has been, especially right now, an incredibly difficult and stressful time for so many people.
Absolutely.
So we have to give everyone some grace right in through here,
Right. I'm going to try to combine two questions. One talks about health disparities in Baltimore being the direct result of a long history of inequality and systemic racism. And it talks about, number one, has the presence of Johns Hopkins in the community helped to slowly change these disparities? And if so, in what way?
Yeah. Well, I don't know if I know the full answer to that. All I know is that, Johns Hopkins certainly has a lot of programs in place and makes a lot of efforts, Some people may not see the effects of it, and maybe there may be some harms that have come about through the ways in which they have, brought these programs into existence. So, I'm speaking on behalf of myself as an individual. I just want to be clear that I'm not speaking on behalf of Johns Hopkins. All I do know is that there are people within the institution who are authentic and who are deeply committed to the community. And I know that there are a number of programs that have been developed by those kinds of people with those things in mind and in partnership with others from the community. It may not be across the board, and I'm sure there are continual problems that are going on. There's still a lack of awareness. I'm within this system and I'm working, a lot of times I experience frustration myself by people not seeming like they get it. They don't understand the bigger picture. They're not really engaging or listening to people who they should be listening to. But all I'm saying is that there are systems are made up of people. And so there are individual people within that system that are working very hard to do the right things. And, all we can do is sort of hope that we grow stronger by increasing the numbers of people that are doing that, and that we work every day to sort of enhance the awareness of the others who are not really doing that for whatever reason they may be not doing it.
Couple other questions. Do you feel that the MCAT should be the determining test for medical school?
No, I don't. I think it's not actually even being used by a lot of medical schools right now. So I don't even, I think one thing that I know is that they've actually they've added a writing requirement, which they didn't have before, which I think is really important. I think doctors need to know how to communicate both verbally and in written form in a clear way. They need to understand humanities and history and not just science. So I think that looking at people holistically, to see what kind of physician would they be, would be much better than determining how they perform on a standardized test that is just testing like factual knowledge about science. So I think a holistic, approach to evaluating people's potential to be a good physician is best.
Okay.
Mhm.
Question, and we're winding down with just a few minutes to go. But one of the questions is, how do you translate academic research into the engagement of community physicians in really feasible interventions that make real and lasting changes?
Well, I know that person who asked that question needs to come and work with me.
No, that was my question.
I was going to say, because it's pretty hard to do. I can tell you that. I don't know if I made it clear today, but this work is really about relationships. It really is about building relationships with people. You cannot bring about any of these changes. You cannot get people to do anything without knowing who they are, what they care about, what's worrying them, and what they hope for, and what they value most, right? And so that's what it is. It takes a lot of time in getting to know all these people and getting to know what it is that they're facing, what their challenges are, and how what you're trying to share with them can help them. And that it's not just something that you're like adding on as another burden or responsibility for them. So I think that's what it takes to do that. And it's a lot of work and it's a lot of time. Sometimes it seems very exhausting and like nothing's ever going to change. And when the change happens, it's incredibly rewarding.
All right, I have one question from Stephen Ragsdale, and he talks basically about being well-resourced does not isolate you from having bad outcomes. And he used an example, mother and baby statistics in DC are horrible despite income. So how can you kind of talk about race and poverty and being well-resourced and still having all of these negative outcomes?
We've had centuries of injustices and harms done to us as a people. And that has really resulted in biological changes in our bodies that make us die at younger ages and experience the stresses that we experience. It's hard to always quantify those things. It's intergenerational stress, right? It's things that have come down from generations. That's one of the most painful things, I think, to accept, is that yes, your parents may have overcome so many things and you may have so many advantages and opportunities now, and still some of those harms are still part of who we are, and are not who we are, but our experiences as human beings.
Right.
So, I mean, it's going to take a long time, but we can only do the things that we have control over. That's what we can control, and it's to engage in like deep level of self-care and support of one another and doing all the things that we know are in our own best interest. And a lot of those other things are out of our control at this point, but all we can do is try to make it better for the generations that are coming after us.
Mhm. Well, I want to, definitely thank you on behalf of the Sibley Senior Association. I want to thank you for the excellent book, Why Are Health Disparities Everyone's Problem? And I want to leave you with perhaps a minute or two. Any final thoughts, anything to inspire us, those of us that do want to do everything that we possibly can to, health disparities?
Well, what I'll say is that I think whenever like it seems like the going is like tough or like how can we do this? I think about, like I said, those among us who have overcome so many different things. I think about those who went before us, who have overcome so many things and thrived. And I just think about our remarkable strengths, as a people, and the remarkable talents and gifts we have to offer. And even, the strength of our faith. And I think that is what keeps us going. And I think about our young people who are, coming along behind us and all the hopes and dreams they have and all the talents and gifts they have. And that inspires me. And so I think that's what I'll leave you all with, is those very same things.
Well, Dr. Lisa Cooper, thank you so much. And thank you to our audience that has come up with some wonderful questions. Thank you for attending. And yes, this was indeed recorded, and you will get a link to the recording very shortly. And again, we thank you so much, Dr. Cooper.
Thank you so much for having me.
Absolutely. Good evening to everyone.